thank you, and good morning. I hope you're all very coffeeed up. I know I am. I actually don't drink coffee, but I drank a cup this morning, and I had breakfast, which I never do. So I'm excited to go over our quality strategy with you. And it hardly seems like it was a year ago since we unveiled our CMS's 16 strategic initiatives. And I got to tell you, I couldn't be more prouder and thankful for the hard work of the CMS team and for efforts from all of you in the audience. We really did set a high bar, but our team has really delivered. And setting a high bar is what we do at CMS. And if you think it's hard on the staff, you should ask my kids how they feel about the high bar set at home. Clean rooms and good grades, all that kind of stuff. So as we work on these initiatives, we're also quantifying and measuring our progress. And we've identified objectives and key results for each of these initiatives to hold ourselves accountable. And CMS also has 3 main objectives, which are improve the quality and affordability of healthcare for all Americans, drive American healthcare towards payment for value, not volume, and lower the rate of growth in America's healthcare spending. But as you can see, quality is a top-tier objective, and without it, efforts to lower cost and improve access are meaningless. And what good is health insurance if the care that you get is shoddy? And there is a unique role for government in ensuring quality and affordability in healthcare. And just as the government sets standards and guidelines for restaurants and regulations for airline safety, government should define essential health and safety requirements to protect consumers. Consumers should feel confident that government is doing its part to ensure that hospitals provide safe care, that nursing homes are places where we want our loved ones to reside, that laboratory tests are accurate, and that hospice care is provided with dignity. CMS has an outsized role in quality, not only because we are the nation's largest insurer, covering more than 130 million Americans, but because we set the safety and quality guidelines for every healthcare facility that receives Medicare reimbursement. And we believe government is responsible for creating and preserving a level playing field for competition, and that involves setting guardrails and minimum standards so patients are protected and providers can compete to provide the highest quality care possible. It involves ensuring that performance can be measured and that data is transparent so patients can make informed choices when selecting providers. The Trump administration has taken many actions over the past 3 years that demonstrate this renewed focus on quality. And they include several presidential executive orders on quality and price transparency, advancing American kidney health, strengthening Medicare. And in implementing these executive orders, CMS is doing its part to advance the Trump administration's vision for quality. And so today, I want to unveil CMS's new, reimagined quality strategy that will implement that vision. Last year, we launched a framework for ensuring safety and quality in nursing homes. And this framework has shaped all of our work on nursing home quality. And in fact, it's been so successful that we've decided to replicate it across the entire agency and in all of our programs in 2020 and beyond. So first, we will establish clear and reasonable expectations for quality by setting government standards and quality measures. In other words, the rules of the road. Second, we will strengthen our oversight and enforcement of those standards to ensure accountability. And third, we will promote transparency, competition, and consumer choice by providing the public with the information needed to make decisions about their care. And fourth, we will work to modernize quality improvement efforts for all through advances in data analytics and technology while prioritizing resources for those that need it most. So allow me to take each pillar in turn. So first, when patients visit a healthcare provider in America, they expect a certain standard of care. We all do. And government has a solemn obligation to safeguard that confidence and security on their behalf and to prevent harm. And unfortunately, 10 years after the release of the landmark publication, To Err is Human, which shined a light on the frequency of adverse events and their consequences, we continue to see chilling instances of unacceptably poor care. Just last year, a patient received the wrong blood due to mislabeling of blood specimens, and tragically, this resulted in the patient's death. An investigation of the facility responsible revealed that more than 100 other incidents involving problems with labeling had occurred. And we've seen a nursing home failing to lock its doors, enabling a resident with dementia to wander almost a mile away, later to be found face down in a sewage drain with broken bones. Such instances represent dramatic, sickening failures of the system and underscore the need for robust government action as well as collective action from all of us to safeguard patients. But government action shouldn't lead to a set of overly prescriptive regulations that stand in the way of patient care, thwart innovation, and drive up costs. Government must set standards that are reasonable and focused on outcomes rather than simply adding to the administrative burden that takes providers away from providing high-quality care. So in early 2017, President Trump ordered all federal agencies to cut the red tape across government agencies. And CMS's response to the president's directive started with a comprehensive review of our rules under our Patients Over Paperwork initiative. And last September, we finalized revisions to the conditions of participation for a dozen different settings of care. And these common sense changes strip away onerous processes and rules and replace them with requirements focused on outcomes and to the greatest extent possible, alignment across provider types for consistency and fairness. And all told, the Patients Over Paperwork initiative, which I think we talked about at this quality conference a couple years ago, has already saved an estimated $6.6 billion and 42 million burden hours through 2021. Time and resources that can be instead devoted to delivering high-quality care to patients. And we're not done with that effort. We continue our work. And another example of our efforts in this area is our modification of standards for organ transplant organization under President Trump's Advancing American Kidney Care initiative. 113,000 Americans are on wait lists for life-saving organ transplants, 20 of whom die each day. And we know the nation is currently discarding nearly 20% of the kidneys made available for transplant. And so we issued a historic proposal that will increase the supply of life-saving kidney transplants for people that are on these wait lists. And also as part of our Patients Over, it's great, and thanks to, and many of you in the room have really helped us with these regulations, and we thank you for all of your help. And part of our Patients Over Paperwork initiative, we've also started to tackle the world of quality measurement. Now, as an audience of quality professionals, I know you all have your favorite quality metrics. But the reality is there's just way too many favorites, and the reporting of these metrics has been an expensive burden on the healthcare system. The Meaningful Measures initiative that I launched in 2017 introduced a framework which sought to focus measurements on outcomes, reduce burden on clinicians, and align measures across all of our programs and try to have more private sector collaboration so that we could make sure that measures were consistent and providers weren't measuring more and more quality metrics that didn't align across programs and across payers. And so we started with a multi-stakeholder process to get input, and the response was tremendous. And so again, thank you to all in the audience that have been a part of that process. It has really shaped our effort to eliminate dozens of unnecessary or topped-out measures. And these measures we've essentially taken out 18% of all measures for projected savings of $128 million and 3.3 million burden hours through 2020. So round of applause for all of the folks that were involved with that. The Meaningful Measures framework also informed our overhaul of the Merit-Based Incentive Program, or MIPS. Instead of hundreds of measures across multiple categories, we are establishing MIPS value pathways for which physicians will be able to pick sets of measures that clearly relate to their specialty or the type of patients that they see. And more importantly, measures under MVP will be developed with the help of physician specialty societies, so they will be meaningful to physicians. We are now embarking on the launch of Meaningful Measures 2.0, and it will go far beyond the mere elimination of measures and point us towards a future in which quality is only measured electronically. So imagine a world in which clinicians don't have to lift a finger, where quality measures can be seamlessly transmitted from their EHRs. And this data might then be combined with other data, claims data, inspections data, surveys. And in an era of artificial intelligence, this might mean more easily identifying providers delivering high-quality care and those that need interventions. In this new world, we would be able to identify quality problems before patients are harmed and intervene accordingly. And that's the vision of Meaningful Measures 2.0. And we're also working to more fully incorporate the voices of patients in measure development. And I know that we have patients and families in the audience today, and we want to measure what matters to you and to all of us. And much of this progress will be made by leveraging technology through the FAST Healthcare Interoperability Resources. That's a mouthful, so we just call it the FHIR standards. And so the FHIR standards, these are standards for exchanging clinical information through application programming interfaces, another wonky term, APIs. But FHIR allows clinicians to submit quality information through digital sources one time for many uses. And this will pave the way for stakeholders to submit data to a centralized submission system, and the receiving system can then perform the measure calculations and exchange data and results with several application quality programs, removing the burden from the submitter to submit data multiple times. And you're going to hear a lot more about our Meaningful Measures 2.0 framework in the next several months, so take a look at the upcoming rules. So with the basic rules of the road established, we can now move to enforcing them. And that brings us to our next pillar, strengthening oversight and enhancing enforcement. And allow me to say up front, this is not business as usual. Medicare's basic safety and quality standards are useless without robust enforcement. Now, CMS has broad enforcement tools at our disposal, starting with our relationship with state survey agencies and accrediting organizations. CMS doesn't actually directly inspect the 5,000 hospitals and 15,000 nursing homes that participate in Medicare. We partner with states and accrediting organizations to conduct inspections on our behalf. So as part of this process, we want to make sure that every provider across the nation is held to the same standard no matter who inspects them. But unfortunately, this has not always been the case. For example, one of CMS's key enforcement tools is civil monetary penalties, or CMPs, and these penalties can be levied on nursing homes in cases of serious noncompliance that endanger patients. According to our own data, we saw that CMPs were being levied at a level 8 times greater in some parts of the country than in others. And even accounting for geographic differences in quality of care, this variation was one that called for an explanation. CMS has a network of 10 regional offices across the country, and while they all operate under the same set of rules, we saw some opportunities for better coordination, communication, and alignment. And so last year, we reintegrated our regional offices with the central office to ensure that our policies are consistently applied across the nation. We're now using the same set of tools, conducting reviews in a more systematic and objective manner, and using data analytic tools to evaluate the performance of reviewers. And we're also submitting cases with significant issues to a committee of CMS staff from across the nation to ensure that enforcement decisions are fair and consistent. And just as our regional offices underwent a complete overhaul, so must our relationship with states and accrediting organizations acting on behalf of CMS. We have improved oversight of state survey agencies by clearly communicating our expectations to them and to the nursing homes they inspect. So they have no question about how we measure performance. So for example, we have seen inconsistency related to how state survey agencies perform their role. And last year, we revised the program used to assess the SSA's performance, known as the State Performance Standard System. These revisions include new and better applications of data to monitor performance and ensure that states are protecting residents from harm consistently across the country. And moving forward, we're looking at ways to set clear timelines for SSAs so they know the expectations for arriving on site to investigate allegations of abuse and neglect, and if necessary, refer to law enforcement for additional support. And we're also looking at ways to enhance our oversight of accrediting organizations. In recent years, we've identified inconsistencies in the way accrediting organizations inspect providers. Some even use standards that differ from our own, which is simply not acceptable. Receiving CMS's authorization to inspect and deem healthcare providers compliant with Medicare's quality standards is nothing short of assuming a sacred public trust responsibility. But an increasing amount of evidence indicates that accrediting organizations are not living up to that high bar. The recent spate of serious deficiencies at large hospitals rising to the level of patient harm and sometimes even death, that accrediting organizations had deemed compliant with Medicare standards is deeply concerning. And our concerns are not only heightened by the growing trend of accrediting organizations providing fee-based consulting services to the same organizations they accredit, a glaring conflict of interest. And it's worth noting that we don't allow these kinds of relationships in other parts of CMS, like QIOs in Medicare or external reviews in Medicaid. And we've already put out an RFI to seek comment from stakeholders to ascertain the scope of the issue. And you're going to see more from us on this issue in the near future. The government's obligation to develop and enforce essential standards for safety and quality is a critical one. But it's only the start of the story. Those essential standards represent the groundwork for a safe, fair, and competitive market, which empowers patients to make decisions for themselves, which brings me to the third pillar of promoting transparency to foster competition and consumer choice. Last June, President Trump released an executive order on price and quality transparency. And the purpose of this order was to empower patients to choose the health care that's best for them. To make fully informed decisions about their health care, patients must know the price and the quality of a good or service in advance. Now, price transparency often makes the headlines, but quality transparency is equally indispensable. If we fail to equip patients with accurate and understandable data about the quality of their healthcare providers, we have a market in name only. Patients may choose actually a higher price provider under the faulty assumption that they are providing higher quality care. So in short, patients will be unable to make good decisions about value. And so CMS is doing its part to promote transparency. We are making more quality data available through an API format so that innovators in the field can also use the data to help make it useful for patients and to identify high-quality providers. And we are also improving CMS's Compare tools, our most important means of publicizing quality of care information for patients. And later this year, we will launch a new tool that houses all of them under one roof. So giving patients a consistent look and feel, and patients will be able to go to one source for quality data on different types of providers. And so if you stop by CMS's booth while you're at the conference or one of our breakout sessions on Wednesday afternoon, you can actually even test out a prototype and give us your feedback. These improvements will build on major actions that we took this past year across all of our programs. For instance, the decision to place a loved one in a nursing home is a wrenching one. And in the past, prospective residents or their families could access information about nursing homes cited for abuse, but only by clicking through multiple screens. It was very difficult to find this information. And in short, you had to know exactly where to look and how to do it. And so last year, we added a new alert icon to our Nursing Home Compare website that identifies providers cited for significant cases of abuse or neglect. And I know some of the nursing homes didn't like it, but we felt like it was the right thing to do for patients and their families. In the individual market, we required all exchanges to publicly report 2019 quality rating information on their websites to help consumers compare and shop for qualified health plans. And likewise, we're proposing additional improvements to the star ratings for Medicare Advantage plans. And the agency is proposing to increase the impact of patient experience and access measures have on a plan's star ratings, as that we recognize that one of the best indicators of a plan's quality is how enrollees feel about their coverage experience. And also in Medicaid, as you saw in the video, we released a new scorecard to increase public transparency about the program's administration and outcomes. This is usually the number one or number two expenditure in states, and the public deserves to understand the performance of state Medicaid agencies and their outcomes and how they're improving the lives of beneficiaries. So for CMS, quality transparency is a full-spectrum, system-wide endeavor spanning all of our programs. But last, but certainly not least, is revamping our approach to quality improvement activities at CMS. Traditional quality improvement activities have been effective in important ways, such as a nearly 9% reduction in readmissions to hospitals, a 32% decrease in catheter-associated urinary tract infections, a 25% decrease in central line-associated bloodstream infections, and a significant reduction in the rates of other areas of harm, such as surgical site infections. And most of you in this room contributed to these great results, and thank you for all of your hard work. And while these efforts have helped to move the needle, a more fundamental and transformative change is called for. Estimates persist of thousands of errors still occurring in this country each year. And in many cases, we continue to pay for substandard care. Quality improvement should be top of mind for every healthcare provider in the country, from the largest regional health conglomerate to the smallest solo physician practice in a rural town. But while quality expectations are always the same, the resources needed to achieve them are not. Larger healthcare systems are more likely to have the necessary resources at their disposal to commit to these kinds of internal processes and personnel, and even cultural changes. But the small-town doctor's office may be the only source of primary care for miles and may not have the means to make the same changes. As many of you are aware, we have made some significant changes in the QIO program this year. The work of the QIOs is important and cannot be understated. And going forward, we want to focus their expertise on providers that need it the most. The new QIO goals will focus on increasing patient safety, chronic disease management, quality of care transitions, nursing home quality, and certain behavioral health areas. And going forward, the work of the QIOs will be targeted to low-performing providers in rural areas who serve vulnerable populations. And at the same time, it's time for larger health systems to continue to double down on quality improvement by making their own investments in quality, independent of government-funded assistance. And as we make quality results more transparent to the public, their commitment to improving quality will only grow. At every turn, the Trump administration is seeking to empower patients to be better consumers. For too long, when navigating the healthcare system, patients have been buffeted by winds outside their own control. They have lacked understandable and accessible information on price and quality, and they haven't been adequately protected against lapses in quality. And they've had their choices curtailed by a system that doesn't give them the means to reward high quality by voting with their feet. Our administration is committed to reversing that paradigm, to setting and enforcing standards for quality that are focused on outcomes rather than processes, and after leaving quality in the hands of consumers and providers to work out between themselves. In closing, thank you for coming today. We have an exciting few days planned. You're going to hear from some of our top leadership about our 16 strategic initiatives, all the progress that we've made, and all of the things that you can expect to see this year. We're also joined by Dr. Jawah from HHS, and so you get to hear about some of HHS's efforts as well. The Trump administration is charting a path towards higher quality and lower cost care for all Americans. Thank you for being with us today.
Please welcome CMS Deputy Chief